Hello, everyone. Let's get started. My name is Alan Hudson from the Immuno-Oncology Translational Network Data Management Resource Center. I also serve as Chair of Biostatistics and Bioinformatics at Roswell Park Comprehensive Cancer Center. Before we start the seminar, I just have a few bookkeeping items to go over. Questions will be responded to at the end of the second presentation. Please enter your questions in the Zoom Q&A box, not the chat box. The audience can prioritize the order of the questions by clicking on the thumbs up button. Closed captioning is available. The closed captioning for today's webinar can be accessed by clicking on the live transcript option in the Zoom menu at the bottom of your screen. Instructions are also provided in the chat box. If you're having technical issues, you can make a comment in the Zoom chat box. With that, I would like to turn the proceedings over to Dr. Leah Mechanic, who is a program director in NCI's Division of Cancer Control and Population Sciences for the Participant Engagement Cancer Genome Sequencing Network, which is one of the programs designed in response to the recommendation calling for a network for direct patient engagement as part of the Cancer Moonshot efforts. Dr. Mechanic.
Thank you, Alan. In support of our next generation of cancer researchers, today's Cancer Moonshot seminar will feature research from talented junior investigators or early career scientists. These are abstract-driven presentations that were nominated by Moonshot investigators and selected by NCI staff. We are delighted to feature the science from Dr. Kelsey Laumin and Dr. Mary Frances Wedekind Malone, talking about both patient engagement and implementation science. And we're grateful for Dr. Perdita Drake, who agreed to serve as moderator for this session. And with that, I'm going to introduce Dr. Drake. Dr. Drake is a professor of surgery at Washington University School of Medicine in the Division of Public Health Sciences and the Associate Director of Community Outreach and Engagement at the Siteman Cancer Center. Dr. Drake is a cancer epidemiologist and health disparities researcher whose research focuses on identifying preventive strategies to reduce racial and ethnic disparities. Dr. Drake is a multiple principal investigator on the Washington University Participant Engagement in Cancer Genome Sequencing, or PECGS Center, where she leads engagement optimization part of the project. Dr. Drake's team will seek to understand the patient's concerns, values, and sort of information they would like to receive after having their tumor sequenced. Moreover, Dr. Drake's team will work with the Program for the Elimination of Cancer Disparities and the Patient Engagement Advisory Board to help guide the research study design and engage with potential participants. And with that, I want to turn it over to Dr. Drake.
Thank you, Leah. I'm excited to introduce our first early career Cancer Moonshot speaker for today, Dr. Kelsey Laumin. Dr. Laumin is a senior research fellow in hematology and oncology and a postdoctoral fellow in genomic medicine at the University of Pennsylvania. Her research focuses on the design of innovative strategies to bridge the evidence to practice gap in cancer care, with a particular interest in the dissemination and implementation of precision oncology into routine clinical practice. She received her undergraduate degree in economics from Rice University, medical degree from Baylor College of Medicine, and Master of Science in Clinical Epidemiology from the University of Pennsylvania. Welcome, Dr. Laumin.
Thank you so much. Let me go ahead and share my screen. All right, thank you again, Dr. Drake, for that lovely introduction. It is such an honor to be here today and to have this opportunity to share some of our work in which we are seeking to leverage the electronic health record to optimize care for patients with inherited cancer syndromes. We know that the diagnosis and management of patients with inherited cancer syndromes is a multi-step process that involves first identifying patients who are eligible for germline genetic risk evaluations. Second, referring those individuals to the appropriate clinical genetics care. Third, completing a genetics evaluation, which typically involves some combination of pre-test education, shared decision-making, and testing. And finally, interpreting those results and their implications for clinical management. But with each of these steps of this process, there's the opportunity for patients to actually fall through the cracks. We recently conducted a study of nearly 1,800 patients at Penn who had been diagnosed with a solid tumor between 2017 and 2019, and who at the time of diagnosis met national best practice guideline recommendations for germline genetic risk evaluation. Among the full cohort of patients, all of whom were eligible, we found that only 60% were actually referred to genetics within 1 year of diagnosis, and even fewer patients went on to be evaluated and tested. Then when we focused on a smaller subset of individuals who went on to be diagnosed with a specific inherited cancer syndrome, Lynch syndrome, we observed even greater drop-off in the number of patients who were appropriately managed for their increased cancer risk. As such, it's clear that there is a critical need to bridge the evidence to practice gap in cancer genetics care. And that's really where the field of implementation science can come in. In essence, implementation science is the systematic study of exactly how we translate evidence-based practices into routine care. And it uses a series of theories, frameworks, and models to inform the development of what are called implementation strategies, which can then be rigorously evaluated. And so today I'd like to walk you through how the electronic health record, or the EHR, can actually be used to integrate these types of implementation strategies into clinical care. And much of that actually has to do with the fact that in 2010, the passage of the Affordable Care Act actually mandated the use of the EHR in all clinical settings. And so since that mandate has gone into effect, or went into effect in 2014, we've actually had a relatively low cost, sustainable, and even scalable tool right at our fingertips. And so when applied to the cancer genetics space, EHR-based implementation strategies can actually be leveraged to facilitate each step in the diagnosis and management of patients with inherited cancer syndromes. Today, I'd like to walk you through two of our ongoing projects in which we're seeking to do just this. We're using our EHR, which is entitled PennChart, which is an instance of the Epic EHR. The first project focuses on default genetic referrals for patients with young onset colorectal cancer. And it really hones in on these first two steps of identifying patients who are eligible for a germline genetic risk evaluation and then going on to refer them to the appropriate care. By way of background, we know that young onset colorectal cancer, which is defined as a diagnosis under the age of 50, is increasing in incidence at alarming rates. Most of these patients are actually diagnosed between 40 and 49 years of age, but we're finding that that age group is actually rather unique and underserved, in part because they're actually not included in young adult cancer initiatives, including our very own Moonshot-funded GenY study going on at Penn. But regardless of the age at diagnosis, all patients with young onset colorectal cancer are actually recommended to undergo a germline genetic risk evaluation to look for Lynch and a variety of other inherited cancer syndromes. But when we did a preliminary analysis of about 50 patients who were diagnosed with young onset colorectal cancer in 2019, we found that fewer than half were actually referred within a year of diagnosis, and that there were significant disparities between the group that had been diagnosed under 40 years of age and those in the 40 to 49-year-old age group. And so we actually developed this pilot study specifically to develop, implement, and evaluate the effect of a default genetic referral process for patients diagnosed with young onset colorectal cancer between 40 and 49 years of age. And we predefined a 60% referral rate as our threshold for feasibility. AIM2 is beyond the scope of today's talk, but is also seeking to assess the feasibility, acceptability, and appropriateness of this process among both patients and clinicians. And so what does this process look like? We are using the EHR to identify patients who are eligible for germline genetic risk evaluations, after which we get in touch with these individuals' clinical oncology providers first, notifying them of their patient's eligibility and giving them about a week to respond. If they haven't opted out by a week, we then move forward and actually notify the patients themselves of their eligibility for a referral, as well as the national recommendation that they do move forward. And patients are given a 2-week interval to respond, after which we then move forward with a genetic referral, which involves scheduling, evaluation, and testing as per routine standard of care. And so in the subsequent slides, I'd like to walk you through exactly how we've been able to leverage the EHR to facilitate each step in this process. The first step involves just identifying patients themselves. And for that, we've been using the reporting workbench tool that's available in Epic. And this enables us to pull a report in real time of all patients who are eligible for a genetic evaluation. But we recognize that as we were developing the logic behind this patient identification algorithm, we needed to strike a delicate balance. On the one hand is the full potential of the automation and computing power of the EHR. But on the other side are more practical considerations. How accurate is this algorithm? How transparent and understandable is it to end user clinicians? And ultimately, how scalable is it going to be? It's one thing if we develop the most sophisticated algorithm under the sun that costs millions and millions of dollars to create, but if that no longer translates to other practice sites, that could be potentially problematic. And so to strike this balance, we ended up deciding to use a combined approach where we leveraged both algorithmic identification coupled with manual verification, sort of as this first step in an incremental approach to developing an EHR-enabled patient identification algorithm. You'll see on the left that the algorithmic approach to inclusion criteria included discrete variables that are available readily in the EHR, things like ICD diagnosis codes, associated dates, and ages of patients. We also included several criteria to really ensure that patients were active within the Penn Medicine system at the time of study entry. And then we also ensured that we were manually verifying each of those inclusion criteria on the back end. We deliberately also chose not to include exclusionary logic, at least in this initial phase. And so we did also manually review each patient who had been screened to determine whether they had previously been referred to cancer genetics prior to study entry. So far, we've screened 160 patients using our EHR-based patient identification algorithm, of whom 29 were actually deemed not to be eligible for genetic referral on manual verification. That left 131 patients who are eligible for participation in our intervention. But actually on manual review, we found that 78 or about 60% had actually previously been referred to genetics. So we're already doing a little bit better than our 2019 data, but that still left 53 patients who are eligible for participation. And so moving forward, we then notify these patients' clinicians using the in-basket functionality in Epic. Essentially, this is a templated message sent out to a patient's medical, surgical, and/or radiation oncologist, letting them know that they're eligible for a referral. And if they're in agreement, we move forward with the patient notification. And this is a screenshot of what that templated message looks like. For this, we've been using the electronic patient portal to notify patients of their eligibility and the recommendation that they move forward with a genetic referral. But I will comment here that not all patients were actually actively enrolled on the portal at the time of our study. And so we ensured that there were backup mechanisms in place to notify them via email or phone call as appropriate. Then, as we moved forward with genetic referrals, we then used the same in-basket functionality to facilitate that process. And so how have we done so far? As I mentioned, we screened 160 patients using our EHR-enabled patient identification algorithm, of which 53 were eligible for participation in the default genetic referral process. That meant 53 clinician notifications, and only one clinician opted out due to financial concerns for an international patient. That then meant that we have sent 52 patient notifications. 3 opted out, actually asking to discuss this issue with their oncologist first before automatically being referred. And so that left actually 49 patients who actually moved forward with the genetic referral process. That translates to a 92% referral rate, well above our predefined feasibility threshold. Though I will say we were a little bit concerned we might have sent these referrals without patients' knowledge. And so for that, we actually evaluated fidelity as well and found that at least 83% of patients did indeed receive these notifications, either because we were able to get in touch with them directly via phone or that we had gotten a read receipt from the electronic patient portal. Currently, patients are actually being scheduled, evaluated, and tested as per routine standard of care, and we'll be evaluating those secondary outcomes in the coming months. And so even though this is an ongoing study, we've already learned multiple lessons that are informing future work in this area. First, a default genetic referral process does appear to be feasible for patients with young onset colorectal cancer, at least with respect to referral. We recognize that the impact on downstream scheduling, evaluation, and testing rates is still yet to be determined, and we'll be eager to see what that looks like in the coming months. A second observation is that additional mechanisms are going to be needed to streamline the patient identification process. As I mentioned, we actually screened 160 patients to identify 53, of whom were ultimately eligible for our intervention. Much of that was because of the deliberate decision not to include exclusionary logic in this initial algorithm. And so moving forward, it'll be important to include structured data elements from the EHR, things like genetic referral orders, encounter data, and even discrete genetic test data to then build more sophisticated algorithms. Another observation was that any EHR-based care delivery innovation must still include patient communication modalities that live outside of the EHR, whether that's via phone call, secure email, or text messaging. We know that there are clear disparities in electronic patient portal enrollment. And so we have to make sure that any EHR-based implementation strategy does not actually lead to differential uptake in evidence-based practices, and certainly does not lead to widening of existing disparities in care. And finally, it remains to be determined whether the traditional clinical genetics delivery model is actually going to be able to meet the increasing demand of patients in need of germline genetic risk evaluations, not only within the young onset colorectal cancer space, but even beyond that. We'll be able to determine that in the coming months by evaluating our secondary outcomes. But in the meantime, it's important to make sure that we're streamlining clinical genetics care to the best of our ability. And I'd like to also call attention to the growing and important body of literature on alternative genetics delivery models, things like telegenetics, point of care testing, and mainstreaming. And so this last point is somewhat outside of the scope of today's talk, and perhaps can be fodder for another seminar on another day. But I'd like to focus a little bit on how we might be able to streamline clinical genetics care in the second project using the EHR. For this particular project, we're focusing on developing and evaluating clinical decision support for patients specifically with Lynch syndrome. And this focuses on the fourth and final step in the diagnosis and management of patients with inherited cancer syndromes. We know that patients with Lynch syndrome are at an increased risk for multiple cancer types, including colorectal cancer, upper gastrointestinal cancers, and a variety of others. National best practice guidelines recommend a colonoscopy for these individuals every 1 to 2 years, depending on their age. But the data are much less well established for cancer screenings in other tumor types. And for that reason, it's important that these individuals stay in touch with their genetics clinician on a regular basis so that we can continue to tailor these guidelines to their individual needs over time. But when we conducted an initial review of nearly 400 patients in our Lynch syndrome registry at Penn, we found that about 70% of patients were up to date with lower endoscopic or colonoscopy surveillance, but only a little over half were actually up to date with their annual GI genetics visits. And so for that, we ended up opting to develop an EHR-based clinical decision support algorithm to try to promote these guideline-recommended cancer risk management activities in patients with Lynch syndrome. And in the long run, we'll be aiming to determine the effect of these clinical decision support tools on the downstream uptake of guideline-recommended cancer risk management activities. And so what does the clinical decision support itself look like? We knew going forward that developing the logic specifically for lower endoscopic surveillance was actually going to be the most complicated. So I wanted to share a little bit of our thought process with you all today. For this, we ensured that we were including both colonoscopies and flexible sigmoidoscopies because either can theoretically be conducted in a patient with Lynch syndrome, depending on their prior surgical history. And there were 2 potential approaches that we could take. I've labeled simple logic here. This is based on best practice guidelines nationally that recommend certain interval screening or certain screening intervals based on a patient's age or their prior history of colorectal cancer. But we also knew that we could have taken a more complex approach where we also incorporated what the specific endoscopist's recommendation was at the conclusion of the patient's prior procedure. And so what we did in comparing and kind of weighing the pros and cons of each of these alternative approaches was we went back and looked at our Lynch syndrome registry to essentially compare simple versus complex logic, and ultimately found greater than 90% sensitivity, specificity, positive and negative predictive value when comparing the simple approach to, say, the gold standard of the more complex approach. You'll see in this table here that we ultimately identified 17 discrepancies, most of which revolved around differences in recommended follow-up intervals. And so as we moved forward with the clinical decision support build itself, we recognized the need to be able to modify these parameters manually if need be. And so ultimately, we developed clinical decision support according to the simple logic that I displayed, not only for lower endoscopy surveillance, but we also ended up building logic for upper endoscopic surveillance, which is a very institutional dependent thing, as well as the annual GI genetics visits that I had mentioned earlier. I'm pleased to share that we went live with this tool in November of 2021. And as of earlier this week, this tool was active for nearly 370 patients in our system. And so how does this actually work in the EHR? We, over the last several years, have actually been able to incorporate Epic's genomics module into our EHR, which then, after a lot of collaboration with the multidisciplinary team, has enabled us to actually import discrete genetic variant information directly into the EHR, which then drives the downstream creation of what are called genomic indicators, which I've displayed in the screenshot here on the front page of a patient's chart. These are essentially tags that indicate the clinical significance that go along with the genetic variants. And these tags then drive downstream clinical decision support. For Lynch syndrome, the genomic indicator assignment revolves around the Lynch syndrome associated genes themselves, as well as pathogenic or likely pathogenic clinical significance denotations, as well as a lack of mosaicism. And this then in turn drives downstream clinical decision support for both clinicians and patients. For the clinicians, they're actually able to see what are called care gaps directly on the patient's homepage of the chart. And when they click on that, that actually brings them to what's called the health maintenance module within the EHR. And this ends up listing out the different cancer risk management activities that we've built logic for. These will automatically update anytime a patient actually completes a visit or a procedure within our system. But as I mentioned earlier, it's still also important that there's at least a stopgap mechanism in place to manually update these topics over time. And that's where this additional module comes in. A clinician can add a completion, say if a patient has undergone a colonoscopy at an outside institution. They can postpone or edit the follow-up based on a patient's priorities at a given point in time or what the recommendation was following a procedure. Or if appropriate, they can even discontinue it. But what do things look like for patients? On the patient side, patients are actually able to see within the electronic patient portal something called the genetic profile. What this is essentially a listing of any of their relevant genetic findings of interest, as well as patient-friendly information that has been curated by genetic counselors at Penn, specifically to describe what the implications of those findings are. They can then navigate to what's called the preventive care section of their electronic patient portal. This shows some of our more routine primary care recommendations, things like vaccinations or average risk mammograms, but this is also where the Lynch syndrome associated topics live as well. And finally, on a population health level, we've actually also been able to use the EHR to essentially evaluate our outcomes over time. This is a screenshot of the slicer dicer tool that we've been using that gives us sort of a snapshot at any given point in time to see how many patients are due for one of these cancer risk management activities. And so we've actually been tracking this over the last several months. We went live with this clinical decision support in late 2021, and we've been tracking on a weekly basis ever since then. And you can see whoever's due for a GI genetics visit in blue, a lower endoscopy in orange, and an upper endoscopy in gray. Now, I'll be the first to recognize that we really haven't seen these numbers budge much in the last 6 months. We hypothesize that that may be related in part due to pandemic-related scheduling delays for both visits and procedures. And so in conclusion, it does appear that EHR-based clinical decision support can feasibly be developed to promote guideline-recommended cancer risk management for patients with Lynch syndrome, though it will likely take years before we actually understand the full impact on downstream guideline adherence and clinical outcomes in these patients. But I would argue we're just getting started. We're still refining the Lynch syndrome clinical decision support algorithms over time. We've begun expanding to other inherited cancer syndromes like hereditary breast and ovarian cancer, von Hippel-Lindau, and Li-Fraumeni syndrome. And we hope that these tools will actually lay the foundation for the development and evaluation of even more potent and sophisticated implementation strategies over time. And so in closing, I hope I've given you at least a high-level glimpse at just a few ways by which the EHR can be used to optimize care for patients with inherited cancer syndromes. And I'd like to thank and acknowledge the many mentors and collaborators who have made this work possible, specifically my primary mentor, Kate Nathanson, and our Moonshot-funded GenWise study team. Thank you so much, and I'll be happy to take questions during the Q&A session.
Thank you, Dr. Laumann. If you have additional questions, we see you guys have already started populating the Q&A. If you have more, please put them there, and we will get to them during the Q&A section. Next, I'd like to introduce Dr. Mary Frances Wedekind-Malone. Dr. Wedekind-Malone is a pediatric oncologist with expertise in immunotherapy and developing clinical trials for pediatric sarcomas and rare tumors within the Pediatric Oncology branch of the Center for Cancer Research at NCI. She went to medical school at Kansas City University of Medicine and Biosciences and received her pediatric residency education at Nationwide Children's Hospital in Columbus, Ohio, followed by a pediatric hematology oncology fellowship. Dr. Wedekind-Malone is the principal investigator for the National History of Rare Solid Tumors in Pediatrics and Adults as part of My Pediatric and Adult Rare Tumor Network, the MyPART network. Dr. Wedekind-Malone's overarching goal is to bring novel agents or strategies to the clinical trial landscape and for these rare pediatric tumors, while also trying to understand the natural history and the molecular genetic profile through numerous analyses of tumor tissue. So take it away, Dr. Malone.
Thank you so much. I will go ahead and share my screen. Okay, thank you so much, Dr. Drake, for the wonderful introduction. My name is Mary Frances Wedekin, and I am a research assistant in the pediatric oncology branch at the National Cancer Institute of NIH and the principal investigator of the natural history study of rare solid tumors in pediatrics and adults. I am very happy to present a brief overview on the Cancer Moonshot funded NCI initiative, My Pediatric and Adult Rare Tumor Network, or MyPART, and the importance of patient and advocacy engagement. Rare tumors across the world are lacking in adequate knowledge, resources, and community. MyPART was developed utilizing Cancer Moonshot funding to engage all of those involved in rare tumors, from patients, family members, and advocacy groups, to researchers and healthcare providers, to partner to improve the lives of young people with rare cancers. Through multi-institutional collaboration, we developed a natural history study, hold workshops, and host multi-day specialty clinics with a goal to collect, analyze, and share all available data to develop an increased understanding of tumor biology and natural history, which will then be translated into new clinical trials. The natural history study of rare solid tumors in pediatrics and adults uses standardized retrospective and prospective comprehensive longitudinal evaluations of patients with rare solid tumors and their families, being led by myself and Heidi Del Rivero. Children and adults at any stage of their cancer journey, including those newly diagnosed or with relapse refractory rare solid tumors, as well as their biological relatives, are invited to join. Participation can occur at the NIH or offsite from anywhere in the world, including their home. After enrollment, patients or their family members on the protocol electronically complete standardized medical and family history forms and patient-reported outcomes. Our team also performs extensive medical record data extraction. With pathology specimens from all patients with a rare tumor received, we are able to complete molecular profiling with results discussed at a multidisciplinary review and then returned to the patient with the help of genetic counseling. All patients are given medical opinions, including clinical trials, not only at the NIH, but across the country or internationally if needed. If applicable, patients with the ability to participate in a sub-protocol where more disease-specific questions are asked. For those who come to the NIH, imaging, biopsies, and surgeries may be obtained if clinically indicated. For participants with a rare solid tumor or those without a tumor but found to have a predisposing germline mutation, we follow up yearly for updated questionnaires, medical record, and biospecimen collection, and provide new treatment recommendations. None of the evaluations performed on the study are billed to the participant or insurance, with funding also to support travel and lodging. In addition to confirming diagnosis from tumor tissue, we look for actionable gene mutations followed by extensive research analysis. We collect saliva from all participants by sending kits to their homes with return envelopes, which is then utilized for clinical and research analysis. For those who come to the NIH, blood samples are collected for detailed analysis and to look for circulating immune cells and potential biomarkers of disease. Since opening for enrollment in 2019, we have enrolled 451 adult and pediatric participants, which include more than 55 different histologies. Enrollment spans 6 continents and 22 countries outside the US, with most states in the US included. Seen here are the tumor types enrolled on our protocol, with the most common including neuroendocrine tumors, SCH deficient or wild type GIST, chordoma, ACC, and medullary thyroid carcinoma. Also, you can see the list of tumor types with only 1 or 2 patients, and we also have 8 participants that have more than 1 tumor. So now that we have briefly discussed certain aspects of MyPART in the natural history study, I want to focus the rest of my talk on a very important aspect to our efforts, our partnership with advocates and patients. As many of us here today are aware, there are numerous benefits of having a strong partnership with advocacy organizations and patients. It adds a human connection and reminds us why the research matters. It ensures there is a patient focus to the research while providing different perspective on the disease. Including advocates and patients in research can lead to more in-depth discussion and understanding, which then leads to further innovation. All of these aspects are critical to make changes in research, especially when it pertains to rare diseases, including rare tumors. So why does MyPart want to heavily partner with advocates and patients? Because increased patient engagement is so much more than just increased clinical trial recruitment. And these partnerships can lead to engaging patients on multiple levels. With successful advocacy and patient partnership, there is a two-way flow of information. We desire to enhance the experience of patients and advocates to improve the patient ownership. Patients want to see not only their own results, but see the results of something they are a part of. But most importantly, in including all stakeholders, we benefit not only the patients, but also the research. To date, we have established 21 advocacy partnerships as listed here. I will go into more details about one example later in this talk featuring the Chordoma Foundation. We are very grateful for these partnerships and look forward to expanding them. Our successful enrollment of rare tumors with very few incidents would not be as successful without our advocacy partners. One unique aspect of our program that requires collaboration with patients and advocacy are our rare tumor clinics. The Wild Type GIST clinic was started 12 years ago by Lee Hillman. During these clinics, 10 to 15 patients with a very select rare tumor are brought to the NIH along with multiple disease experts from across the country and at NIH. Robust data can be collected during this 3-day event, which benefits the research population, but more importantly, the patients can discuss their disease with experts and get to meet other patients with the same tumor. Two things that the patients have likely struggled to accomplish since their diagnosis. We have now established multiple clinics with more to come in the future. Another unique aspect of our natural history protocol is the utility of patient-reported outcomes. In 2019, the FDA provided guidance on the utility of natural history studies for drug development in rare diseases, with a specific mention of the value of patient or caregiver reported outcomes to determine certain clinical endpoints in clinical trials. Our protocol uses 25 validated instruments looking at such things as pain, anxiety, cognitive functioning, and given to children, adults, and caregivers at study entry and then yearly. Data will lead to further defined PRO analysis in our sub-protocols and utilized as external controls in interventional trials. In utilizing PROs, patients have the opportunity to let researchers get a better understanding of their unique experience that can then help other patients. As we all know, COVID-19 was a devastating event in history that truly affected the healthcare system. Our team was not only able to continue to enroll patients, but we also utilized this time to listen and learn from our patients and advocates to adjust our research and clinical landscape. Through our field cohort, we have the unique ability to enroll participants remotely from their homes. In this graph, the pink bars represent our clinic patients that come to the NIH, while the blue bars represents those that were enrolled in their homes wherever that may be, including internationally. This aspect has helped the diversity of our enrollees, as many participants, including those in rural and underserved locations, would have not otherwise been enrolled. This has led to patients feeling more connected to research with better support, and more importantly, connected to other patients with rare tumors when they previously felt alone. Our next goal is to host virtual or in-person when able focus groups to continue to learn from patients and how we plan our future studies. Now to give one example of the power of patient and advocacy engagement, I will go into details about pediatric chordoma, which is a very rare tumor. Over the next few slides, I will demonstrate how a scientific interest led to the collaboration of an advocacy organization, which then drove critically important patient engagement and further collaboration with physicians and scientists across the world. Briefly, chordoma is a rare, slow-growing sarcoma originating from the notochord and occurring at the base of the skull or along the spine and sacrum. There are only approximately 325 new cases a year, with only 5% of those being pediatric. Chordoma can have one of four histologies: conventional, the most common; chondroid, dedifferentiated, or poorly differentiated, which is more common in pediatrics. The distinction is important as this determines treatment, as the conventional, chondroid, and dedifferentiated are primarily treated with surgery and radiation, while poorly differentiated does not have a standard of care, but is typically treated with chemotherapy, followed by local control and sometimes immunotherapy. No matter the type, chordoma treatment requires a multidisciplinary approach, including neurosurgeons, ENT, radiation oncologist, medical oncologist, and pediatric oncologist. The initial spark came from a high interest in chordoma within the intramural research program, leading to a working group to discuss opportunities for progress. This group initiated a national workshop to include laboratory researchers, advocacy, and clinicians as a starting point to collaboration. This workshop was the cornerstone of establishing a partnership with the Chordoma Foundation. The Chordoma Foundation was founded by Josh Summer, a chordoma survivor, in 2007. His organization has grown immensely since that time, with various boards and a yearly symposium. The Chordoma Foundation has become a primary resource for patients with chordoma, physicians, and researchers across the world. With the establishment of a partnership with the Chordoma Foundation, collaboration was formed with numerous of the Chordoma Foundation board members and the MyPart team. With these collaborations in place, discussions occurred to determine the best measures and questionnaires to develop a sub-protocol for chordoma on the natural history protocol. These measures are based on location of the chordoma. For base of skull, extensive neurocognitive testing is assessed. With the mobile spine tumors, overall and neck disability questions are asked. While the sacral tumors, assessment in genitourinary and bowel dysfunction are assessed. Once the sub-protocol was approved, the inaugural pediatric chordoma clinic took place. The Chordoma Foundation was instrumental in identifying the expert clinicians, leading scientists, and patients to participate in the clinic. Without their input, our clinic would not have been as successful. We invited patients from across the world to participate, along with numerous physicians and researchers in the US, to form a comprehensive panel of experts. Through this clinic, we saw very important interactions of scientists and scientists with patients, but also the critical interactions of patients and family members with other patients and family members. For patients with rare tumors, the interaction between another patient with the same tumor, especially for the pediatric, adolescent, and young adult populations, is something that really makes these clinics so special and unique. Here is a snapshot of the participants in the clinic, with 7 of these patients attending in person and 4 of them participating remotely. Again, we demonstrate the importance of remote involvement for all patients to participate, as these patients were either too sick to travel or lived too far away. As you see, most patients had a conventional chordoma, and most patients had several lines of therapy and still, unfortunately, had disease. Following the clinic, the scientific and clinical collaborations continued. Mass General holds a bi-weekly tumor board for patients with chordoma that we not only attend, but also bring our cases for discussion. For most patients, we continue to communicate with our panel of experts from the chordoma clinic to ensure patients from all over the world are receiving adequate care and to give treatment recommendations. We also have collaborations across the US to develop other protocols, such as the neurocognitive effects after radiation in pediatric patients with chordoma. We also are receiving referrals from physicians for the natural history study from across the world. A very exciting opportunity that has come out of the collaborations is the development of multiple pediatric chordoma working groups. Due to the rarity of pediatric chordoma, the natural history is not well understood, and there is no standard of care for the treatment of poorly differentiated chordoma. These working groups are critical to understanding the natural history of chordoma in pediatrics, as there are many disciplines involved and expertise is needed in all these areas. We are utilizing these groups not only for the development of data collection forums, but also in analyzing the data that results. We have continued to work very closely with the Chordoma Foundation and are a referral hub for patients with pediatric chordoma. We have participated in multiple videos and informative sessions to engage with patients on multiple levels. Lastly, one of our major goals of the initiative is the development of clinical trials. Currently, I am writing along with Shavandana Ashkantala a phase 2 trial of 2 immune checkpoint inhibitors for patients with SMARCB1 or SMARCA4 deficient tumors. Due to our foundation built with patient engagement and physician collaborators, we were able to justify a specific cohort for poorly differentiated chordoma despite its rarity. This trial is in collaboration with Children's Oncology Group and is coordinated with NCI CTEP and the Pediatric Early Phase Clinical Trial Network. In summary, the MyPart Natural History Study of very rare pediatric and adult solid tumors collects longitudinal, comprehensive clinical and biospecimen data. Through extensive collaboration with advocacy organizations and patients, disease-specific initiatives can be accomplished. Patient and advocacy engagement is critical for rare tumor research, as their knowledge and participation leads to an additional perspective. We strive to constantly evolve and learn from our patients and advocates, and will continue to do so to improve the lives of those with rare tumors. I would like to thank the entire MyPart team for all the hard work, NCI for the funding and support, and the advocacy research community for the collaboration. Lastly, the patients and families with whom none of this would be possible, without whom none of this would be possible.
Great, thank you so much, Dr. Malone and Dr. Laumeen and Dr. Malone. It's now time for our Q&A. We have several questions already here in our chat. The first question is to Dr. Laumeen. Could a similar EHR approach be used to identify those that are eligible for genetic testing because of family history? Or following up your current study with an automated approach to cascade testing for those that are found to be positive?
Absolutely. I think that's a wonderful question, and certainly an area that needs so much emphasis in this space. I would say that an EHR-based approach can be developed for basically any area where discrete data are captured in the EHR. And so I tell people as we're developing EHR-based strategies that to some degree, we're only as good as the data that we get in. And so if a given institution or a given practice is very consistent in capturing family history data in discrete format. So really ensuring that all family members and ages at diagnoses and specific cancer diagnoses are recorded, then absolutely that can be used with relative ease to build downstream clinical decision support algorithms. I think the more challenging part, though, is whether that first step is actually taking place. I can speak from personal experience in the clinic that it can be very challenging to use the existing EHR frameworks to capture family history. Though I know that that's an area that both Epic as well as other academic institutions are actively working on. So are there more visual approaches to pedigree collection and so on and so forth? So a long-winded answer to saying, yes, in theory, the EHR can absolutely be used to facilitate cascade testing, but we do need to ensure that the systems are in place to accurately actually abstract that data upfront to then ensure that it's as accurate as possible.
Great. Thank you. We'll go to a question for Dr. Malone to make sure we have time to get in questions for both presentations. The question is, I thought you mentioned MyPart targets only solid tumors, but you mentioned some hematologic cancer patients. Do you have an exclusion criteria when enrolling? And could you share how you set up collaborations with these patient advocacy groups?
Yes, great question. Thank you very much. So we do have an exclusion criteria of hematologic malignancies. This is only for rare solid tumors at the current time. And one of the ways that we have discussed with advocacy organizations is we have Abby Sandler. She is our advocacy partner and leads that effort within our group. And a lot of the times we will either with the Chordoma Foundation, because of the interest in chordoma, we reached out to them and gave examples of our network and what our plan was, and wanted to build and let them know we wanted to build a partnership with them. We also have other organizations that are started that we have heard about from some of our patients. So some of our pediatric patients unfortunately pass away, and their families then develop a foundation. And because of their participation in our protocol, we partner with their advocacy partnership. And so there are multiple ways that we are actually able to start these partnerships and really trying to get our word out there so that we can partner with as many as possible, because it is so beneficial to have the partnerships, to have the patient engagement. And so we are open to all the means to get advocacy partners on board.
Thank you. Dr. Lalmin, I'm going to bundle two of these questions together for you. So have you heard how patients feel about receiving their genetic referral process through the portal versus through emails or text messages? And if you could also comment on whether or not these genetic tests are usually covered by insurance and how do you pay for them?
Absolutely, both wonderful questions. And so we actually are actively conducting some qualitative interviews with patients as we speak to really get a little bit more clarity on exactly how the patient experience has been. So we've only interviewed a few patients so far, so I don't have too comprehensive of information as to what that feedback has looked like. But generally, we've actually gotten very favorable responses about this default referral mechanism. I will say that the vast majority of referrals have actually been taking place directly in the electronic patient portal. Just given scalability considerations, that's sort of been our default approach. And then a handful of patients have actually been contacted via phone. But one of the things that we've actually been very consider in doing is actually indicating that a patient's oncology provider or oncology team has indeed endorsed this recommendation. And so we actually wonder if that specific wording and that verbiage is what is enough to convince patients, absolutely, this is coming from my oncology team, it's coming from somebody I know and trust, and then therefore leading to the tremendous referral rate that we've seen. Now, downstream from there, as I mentioned, we actually were very specific in making sure we followed standard routine practice after the referral itself took place. And so that then entails scheduling with our routine scheduler, so we don't have any specific research staff getting patients set up. And then it does mean setting patients up with a genetic counselor for that pretest education component, part of which revolves around what those financial implications will be. And so we're using standard routine practices to really go through insurance coverage and if not financial assistance mechanisms, all of which would ordinarily be used in routine practice as well.
Okay. I have a question for both of you. So given the diverse and complex data types for both the EHR platforms and the MyPart network, could you both discuss two things? Challenges that you've encountered in communicating these complicated data back to the patients, caregivers, and advocates in the community, as well as any potential opportunities in data visualization, innovations, or approaches to better communicate the complex data back to a lay-friendly way to communities.
I can go first. That is a real challenge, and so a wonderful question. It is difficult to bring these discussions back to the patients. We have, for our results, we give our results to the patients with the help of our genetic counselor that is on our team, Margarita Vergata. She will send the results in a secure email to the patient. And then if needed, sometimes the patient doesn't have any actionable gene mutations or anything that needs to be followed up on. But if there is something that needs to be discussed, she will call herself with one of the physicians to discuss these results with the patients. So we take a very hands-on approach to call the patients and really go over in detail the results. Some patients, as we are all aware, in the current moment, they think they understand, but we always allow for the patient to reach back out to us and have multiple conversations with the patient, and if needed, also speak to their oncologist so that the oncologist can then speak to the patient again, because a lot of times it is just you need to hear it a few times to fully understand. And some of the ways that we can do better visualization, I think that one of the things that is coming through these EHRs is the patient portals. And so creating something through those patient portals and having some templated language through there and, maybe some educational pieces, I think is the way to go to really help these patients. So then they can go back to it multiple times so that they can understand it again, show to their oncologist, show to their family members, and things like that. I think that that's probably the way to fully educate the patients and then have it at their fingertips to look at again.
I'd be happy to answer this question from a slightly different spin as well.
Yeah.
So as I mentioned, the genetic testing and disclosure process, that's all occurring as per standard of care at our institution. So really defer to our expert genetic counselors and the approaches that they've been taking for that. But I will say that even our initial default referral messages were actually surprisingly difficult to craft. You'd think that, we just tell patients they're eligible and call it a day. And we actually realized as we were framing those that there's so many different ways that those can be interpreted. There are health literacy considerations, just so much that goes into even just a couple of sentences. And so that's sort of what we're really hoping to glean from our qualitative interviews, getting that direct patient feedback. But I'd also say that that experience was also enough for a future grant proposal that we've been preparing, specifically focused on what is that patient level language supposed to look like? Are there systematic ways that we can actually compare one messaging strategy versus another and really end up actually taking as patient-centered of an approach at every step along that pathway? And so whether it's at the beginning when we're talking about an initial referral all the way downstream to what a results implications mean for a patient and their family, I think that approach may turn out to be very useful.
So I'm going to go back to you, Dr. Malone, and again, try to combine a couple of these questions so that we get most of the questions that are in our Q&A answered. So for patients in the natural history study where they don't currently have a clinical trial, do you follow up later if a new trial becomes available? And if you could also, while we're here, answer a question about the patient advocacy groups. Are they recruited through different, or patients recruited through different advocacy groups different from those recruited otherwise, perhaps through clinic areas? But also, how does that influence, how does the feedback you get from patients influence your protocol or study design? And hopefully that's not too much to answer at one time, but I think they're related.
Yes, they are very related. So I will start with the patients and how they're recruited. We take patient recruitment from any means, from a physician, from the patient themselves, emailing our email box, from the advocacy groups. The advocacy groups, for the most part, will just advertise that they have a collaboration and a partnership with our group, and they will give our email to the patient. So they don't really directly say, oh, this patient is in need. If they do, so for example, the Chordoma Foundation, they receive emails from patients across the world, and they will email me asking if they can give my email address out. And so that is also how some of those referrals happen as well. And that's kind of where the referral hub with the Chordoma Foundation and several of our other advocacy partners comes into play. With how our patients have influenced our protocol, with our extensive data collection from the patients, we had very long questionnaires that were all electronic, but it would take patients a very long time initially to fill out all this information, because we go into extensive family history. We ask extensively about their own individual medical history. After speaking with some of the patients and the struggles that they were having with how certain questions were being asked, how long it would take them to go through all the questions, we really sat down and tried to make it much easier for the patient, change the questions so that they were easier to understand and we could get better responses from the patients. We also pared down on the questions, so not as many questions. Also, one of the other things with the recommendations that we get from patients is with our clinics. At the end of that 3-day specialty clinic, we always speak to the patients to see what they liked, what they didn't like. And so we're always changing those specialty clinics to really go for a patient and family focused approach, so that they get as much as they can out of those 3 days. And I think I'm missing the one question. What was the other question? I can't remember now.
I'm looking at the answered questions. You did talk about patient feedback and how it influenced your protocol. I will look at that and try to bring it back around. We probably have time.
I'm sorry if I missed it.
Do we have time for one more question, Alan?
One more, please.
Okay, so I could give you both an opportunity to do short responses, perhaps. Talking about, there are a couple of questions, there have been a couple of questions on working with patient advocacy groups. One question is really getting at, do you all see the pros and cons? What are some of the pros and cons of working with the patient advocacy groups, seeing what's being done first, and then thinking about what can be added additionally, and then working with those patient advocacy groups to kind of fill in those gaps? Is that how you approached your current studies? And do you think that that's an appropriate strategy? And since we're talking about patients and advocacy groups, are there any benefits to the patients on the patient's end for participating in the study? We'll combine those two. So perhaps Dr. Laumann, if you want to start.
Very happy to. Absolutely. So I know that our studies are actually really interesting in that we have developed an intervention that often then will actually translate into downstream standard of care. But I think through every single step of this process, as we just think about the development of implementation strategies themselves, that's the fact that actually the development is iterative. And I think that's where patient engagement and patient feedback is so important. And so certainly we have gotten some feedback in terms of how to actually initially develop the first pass intervention. But I think what's so key to conducting interviews or conducting surveys after the fact is then to say, all right, on the ground, how well was this received and what can we do to make this even better for that next evaluation? So that's my little snippet where I think the beauty of implementation science in and of itself is that we're never really done. And so if we incorporate patient feedback in that process, hopefully we'll continue to make things even better and more effective in the long run.
So I think we probably have to end there. Is that right, Alan? Thank you
Yes,
both for your time. Wonderful presentations and responses to these questions.
Yes, and thank you, Dr. Drake, for excellent moderation. And again, thank you to our speakers, Drs. Lauman and Wedekind Malone. That was outstanding Q&A session as well. Just a reminder, our next Moonshot seminar series is coming up June 23rd. Dr. Trang from Jackson Lab will be talking about cancer discovery and preclinical validation using patient-derived xenografts. So again, thank you to our moderator and speakers. Look forward to our June presentation.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.